Hey, how's everybody doing? Doing well,
Doing
man.
great, Dave. You?
Good, good. Been busy this time of year, but I'm not trying to cry about that too much. Phase just goes on forever. And the plan was today was to go into a little bit of trigeminal facilitation. Eric, I think we chatted about it a little bit. There's some stuff you'd like to go over as far as what you typically cover in the coursework. I need the lecture material there. They do have an article on it which we could review, but it may be good to get in a little bit of the lecture material that we encourage during that
Yeah.
module.
Yeah, no, it's fine. Let me just kind of go over some basics of it here first, and we'll uh we'll get into it. But basically, if we're looking at um any type of facilitation, the basic premise here is that there's a pool of interneurons that are kind of located in between the incoming sensory components and the outgoing motor components, right? And these interneurons located within the spinal column, basically what happens during a facilitatory effect is they get kind of wound up, right? And so the amount of stimulus that's required for these neurons to suddenly become depolarized and trigger a reaction and send a conduction signal down the chain. So basically from the sensory component through these interneurons and back down the motor chain, the threshold becomes significantly lowered. And so it depolarizes them more often, more often, more often. We get greater reflex responses, higher resting tone, all these different things that come out of segmental facilitation when we're looking at things like, facilitations in the neck or facilitations in the lumbar spine. That's the basic premise of a facilitation. Trigeminal facilitation is essentially the exact same thing. The only difference is instead of it moving into the limb, like it would for the neck or for the lumbar spine, it moves into the head, and into some of the kind of special sensory mechanisms that we have via the cranial nerves. Um, Basically, if we think of the spinal trigeminal nucleus, the spinal trigeminal nucleus is a component of the trigeminal system that's located within the midbrain. Um, Extends down at least as far anatomically that we know of to at least the C2-3 segment in the cervical spine. So that means that things that affect the upper cervical spine, the CV region, down to and including the C2-3 segment, can create facilitatory influences of this spinal trigeminal nuclei. If we start thinking of that spinal trigeminal nuclei as a component of these inner pool of interneurons, right? These neurons are called the substantia gelatinosa. It's a component of the spinal mechanism here of the spinal cord. And essentially what the trigeminal nucleus is, the spinal trigeminal nucleus, it's a continuation of that up into the midbrain. So if we start having abnormal sensory feedback coming from these top levels of the cervical spine, so that's the OA, AA, C2-3, potentially the jaw, or potentially even the teeth, things like that. That's abnormal sensory feedback mechanism, whether it's abnormal proprioception, nociception, however we want to look at it. I think Jim at this point has kind of gotten to the stage where he looks at it as facilitation is purely caused by nociception. Nociception not necessarily meaning that it's reproducing pain at that point, but some of the some of the readings that I've done on it aren't as clear on that sort of thing. So I still tend to mention abnormal proprioceptive feedback as a component that could cause
Yeah.
that sort of thing. Um, but regardless, it's an abnormal feedback mechanism coming from the sensory components here. Um, and basically that winds up this trigeminal nuclei. And because there's a lot of interconnections, a lot of unique interconnections between this trigeminal nucleus and some of the other cranial nerves, um, it can wind up some of these abnormal components within the head. So some of these things can be very unusual, or at least produce unusual symptoms, right? So we think of things like, if you think of cranial nerve 1, right, the olfactory nerve, it's a special sensation, right? Provides the sense of smell. However, when we're looking at the sinuses, the lining of the sinuses, the pressure receptors that we have within the sinus are innervated by the spinal trigeminal nuclei. Okay, so we can have increased sinus pressure as a result of an irritation of the C2-3 within the neck. That's one of the potential symptoms that can come about of this sort of thing, right? So same thing with the muscles around the eye, right? We're looking at cranial nerve 3, 4, and what, 6. Those supply the motor output, right? Being able to move the eyes, but the proprioceptive feedback from those muscles is a trigeminal mechanism, right? So we can get eye pain or, so aching behind the eyes, some of those sort of things. Most of the time, this is going to be unilateral. It's going to be on the same side as whatever spinal segment is producing this facilitatory effect. Same sort of thing with the ear. The stapedius is a trigeminal mechanism, or at least the proprioceptive feedback. Tensor tympani is a trigeminal muscle. These things can cause ear pain, hypo or hyperacusia, so really loud sounds or muffled sounds, depending on what's actually kind of winding these things up. So you can kind of start to see when we look at the different cranial nerves, if you just start going down the list of the 12 cranial nerves, you can start to see how we can get some really weird symptoms that will be a result of this stuff. And there are things that we tend to have to ask about, because a patient will typically come in, they'll say, I'm having these headaches. Okay, where are they? They'll kind of give us the ram's horn thing. That's a typical cervical referral. But if they start talking about like, oh, I get pain behind my eyes, or it really feels like my ears won't pop, or I'm getting ringing in my ears, things like that can be trigeminal mechanisms, but they're still typically caused by issues within the neck. So then we have to start asking about other symptoms, right? Like, do we have any eye issues, blurry vision, or kind of muddy vision, I think is the way it's typically described. Abnormal tastes in the mouth, things like metallic tastes or bitter tastes, jaw pain, tooth pain, sinus pressure, like I said, ear pain, changes in hearing acuity, changes in what else do we have here that I can think of off the top of my head here? Changes in sensory feedback through the face, things of that sort of nature. Any of these sort of things can be related to a trigeminal mechanism. And again, most of these are post-traumatic issues or chronic post-traumatic issues that tend to start to hypermobilize portions of the neck. The most common, at least from my perspective, the most common reason for these things developing is a post-traumatic arthrosis of, say, the right C2-3, where that segment starts to stiffen. We get kind of a capsular limitation of that segment on the right side. So initially, the patient may complain, say it's, post MVA, they may initially complain of kind of a vague, gross, global type of headache, neck pain. Those things tend to calm down after a period of time, whether that's 6 weeks, 8 weeks, whatever it might end up being. Whether they have actual treatment for it or not, just over time, the initial irritation will eventually start to dissipate. What tends to happen then is secondarily, because now we have this stiff kind of muddied segment on one side, is the axis of movement of the facet joints moves from right in between the two joints out to the periphery where that stiff joint is. Now what we have is a segment that's now pivoting around that arthritic or arthrotic joint on the unilateral side. So in our case that we were just talking about, the right side. That would tend to mean that the left side then will start to develop these abnormal sensory mechanisms, right? So abnormal proprioceptions, hypermobile, maybe developing some instability. This is what starts to trigger some of those facilitatory effects into that spinal trigeminal nuclei. And that's going to start to distribute some of those things into the head, face, etc. And like I said, there's some really weird things, nightmares, some cardiac reflexes that can be affected through the vagal mechanisms, churning of the stomach, effects like that. There's all kinds of them, like I said, and we can kind of go over them as we talk about some of the cranial nerves. But it tends to leave us with a very unique presentation, one of which We can kind of see it, a lot of medical professionals, whether, or healthcare professionals in general, whether it's a medical doctor, chiropractors, PTs, massage therapists, whatever it may be, they kind of look at these patients like, all right, you know what? We're not dealing with all that other nonsense. Just tell me about your neck issue or tell me about whatever your jaw pain or whatever it is. And we start to think, well, it's just this localized issue. And we tend to push aside some of these other symptoms. Just because we don't know the connection doesn't mean there isn't a connection. Um, and that's kind of the anatomy of it, right? We don't know where some of these um, neurological uh, interactions can come from, right? And so that's stuff that I think is still very likely needing to be investigated. But we know some of them, and we know the possibility of some of these sort of things. So it's something that we have to look into, because we don't want to dismiss what a patient's complaint in thinking like, oh well, those are probably caused by anxiety, they're probably caused by medications, whatever. We can start looking at all these other potential issues, diet, et cetera. Um, because those patients then just start getting kicked down the line, right? It's like, oh, well, we don't know, we don't know, we don't know. Go see this person, go see that person, and then they end up having all these issues. One of the major, and I will say major issues that will develop as a result of trigeminal facilitation is dizziness. So type 2 dizziness, where it's kind of that lightheadedness. Um, it's very common to have that. So headaches, dizziness, those sort of things will kind of come into play. And we start looking at it with, they also have congruent neck pain. We start wondering about things like vertebral artery compromise and whatnot, especially if it's post-traumatic. But dizziness from a trigeminal perspective is one of the major symptoms that will come up. And when that sort of stuff becomes real bad, it can be one of those very debilitating type of symptoms. I think at one point I remembered reading something saying that undiagnosed or untreatable dizziness is one of the major causes of suicide um, in the United States. And so it's just because the patient they can't function, right? And so they end up, kind of going down this spiral. But it is something that we can help with, that we can treat as a result of being able to diagnose upper cervical mechanical dysfunction. So, definitely something that we have to be aware of, but there are some weird symptoms that'll come along with it. And I'm sure you guys will probably all thinking, at least most of you are probably thinking right now about a patient that came in with some weird complaint, and you're starting to wonder whether or not that'll match up with some of these things. And the odds are it probably does in some way, shape, or form. So for me, that's kind of the easy, I don't know if I'd call it easy necessarily, but the kind of hot and dirty type of description of how this sort of thing works and what it's going to look like for you when you see it in clinic. Trying to look up some other components here. What else you got on that, Dave? Anything else you want to add?
No, I mean thing is you're going to get a sense of it because you're right. It's these nondescript things. It's going to be the dizziness, seeing tinnitus, dull pain, common presentations. Certainly, headaches you could put in there as well to some degree. So there's many causes of a headache you may get with trigeminal facilitation, but the idea of dull pain. I mean, oftentimes you'll be seeing your neck pain patients and you ask them about these other things, they'll have other things going on, to some degree. So how many of your neck pain patients have jaw pain? Or, your jaw pain patients, it's easy. Okay, they're going to have upper cervical pain and they'll have, headache. It's not atypical to see these things reverberate back and forth. I think one thing we saw in the last course was Patrick. I mean, tell us about what you experienced after the first Saturday.
Yeah, so it was kind of towards the end of the day. We had been working on a lot of neck stuff, and I kind of tell that my neck was pretty fatigued from everything. And me and Jacob kind of stopped practicing pretty aggressively. Then it was kind of like a dull ache, kind of like from my ear to kind of midline jaw on the right side that just kind of progressed more intensely.
Mhm. Yeah, so there you have.
I actually have a friend right now that is kind of going through a lot of these similar symptoms. She's having like numbness and tingling on and off in her face, like that follows the trigeminal nerve. she's
Mhm.
getting like whenever she's walking at work, she'll feel like a whooshing sound in her ears that goes like the beat of her heart. And then like if she stands up quickly or sits up quickly, then she gets like kind of lightheaded and dizziness, but she doesn't have dizziness all the time. They did a CT scan of her brain and they didn't find anything. And so her neurologist is diagnosing her right now with like a pseudo tumor. And they're looking further into that, but they can't do anything with her neck. Like, can't do any radiology right now because she's pregnant. So they're kind of at a standstill of like what to do.
I think it's a tumor.
They said it was a pseudo tumor. So it's not like when they did the brain MRI, they didn't find anything. So then they're calling it a pseudo tumor of what could be causing these symptoms. But when she was explaining to me over the weekend, I was kind of thinking like she was in a car accident probably like 2 years ago and went to PT for a while for her neck. And I'm wondering like, is it just something that's like lingering now or wasn't addressed originally?
Well, I mean, the way you're describing it, the whooshing sound, that it's basically you get this hyperacusia and you basically start hearing the blood flow going by your ear through the blood vessels, right? And so that's that sort of thing that you can get with hypertonicity of the tensor tympani. Those sort of things will happen. But yeah, I mean, I would say that sounds very much, and and what's the harm in going, because if they're looking at it and they're saying, well, it's a pseudo tumor, whatever, paraneoplastic, something along those lines, where they're looking at, we have something that's affecting the neurological mechanisms here. They're going on a wild goose chase because they're going to be doing some sort of like total body scan looking for bright spots, and then they're going to have to do they're going to find little things, right? There's going to be all these little doodads in everybody. And they're going to find 3, 4, 5, 8 things, and they're going to do a bunch of damn biopsies on this poor girl, right? That probably are unnecessary. And there's just no harm in going in and examining the mechanics of the upper cervical spine and seeing if there's something that can be done about that there. Because especially a couple years down the road, it's very unlikely that there's going to be any significant risk in treating that area. Or examining that area, right? But yeah, I mean, it kind of follows the pattern we were just talking about, right? Post-traumatic arthrosis of from an MVA, something stiffens up, something else becomes hypermobile, unstable, something along those lines, and all of a sudden you start to get these things that start to wind up, and there's just no real great excuse for where they come from. That's exactly the type of patient that I'd be looking at as potentially having these we call them trigeminal symptoms of cervical origin, or TSCO. But there's definitely a possibility that you could find something like that with that person.
Well, I'll get working on her. Thanks.
Mm-hmm. And the funny thing is you guys already have a lot of the tools that you need to go through and look at this stuff, because it's just basically examining that upper cervical spine, which is stuff that we've kind of been doing on and off already. So there's certainly more to it. There's certainly more things that can be taught as far as that stuff goes. But being able to diagnose like, oh, well, yeah, when we ask her to turn her head to the left, she's limited by 40% compared with going to the right. That essentially confirms that there's a restriction in the craniovertebral region. When you lose that much or that high percentage of mobility and rotation of the neck, right? If it's going to be 2, 3, and there's some processes here as far as trying to rule in C2-3, the OA or the AA. I don't, since I wasn't there for 6, I don't know, what we're looking at with those sort of things.
Yeah,
But we could certainly
we went
go
into biomechanics of upper craniovertebral joint, mobilizations for upper craniovertebral joint. So they
Yeah,
have all the
so
skill set to treat this.
well, so it's one of those things, if you say, okay, turn your head to the left, and she says, yeah, you know what, that gives me a little pain behind my eye and I feel a little ringing in my ears. Okay, well, what's happening on the left side? We're closing everything down, right? So if you're looking at C2-3 potentially as being a problem area, basically what you would do is you'd side bend her to the right, taking C2-3 away from that extension position, and then you'd rotate to the left from that spot, right? And if that doesn't reproduce those same symptoms, then you're probably pretty comfortable saying C23 is the pain producer. It's the thing that's producing these symptoms. And then you can go back and redo these things, just do a side bending motion at C23. If that does reproduce it again, then you're kind of in a confirmatory situation. If it's the OA, AA, you can start looking at it from a situation of what can I do to C1, right? So if I turn the head to the point where I'm starting to develop that, pressure behind the eye or pain behind the eye or ringing in the ears, whatever it may be, I can take C1 and I can change its position just manually, just by hand. So if I'm turned to the left like this, and I take C1 and I turn it back to the right, what's happening at the OA joint? Is that increasing left rotation or decreasing it?
Can you do that one more
Chin
time?
Yeah, so I've got my head, right like this. I turn my head to the left like that. And then I take C1, so I'm turning the head to the left like so. I take C1 and I rotate it back to the right. Does that increase left rotation at the OA joint or decrease it?
Increase.
Increase.
It's going to increase it, right? Does it increase left rotation at the AA joint or decrease it?
Decrease it?
It's going to decrease it, right? So if I rotate C1 back to the right, right? I'm in left rotation. I take C1 and I rotate it to the right. I'm increasing the stress on the OA joint, decreasing the stress on the AA joint. So if I increase the symptoms in that scenario, I'm actually confirming that the OA now is likely the pain producer, right? If I do that same thing, I rotate that back to the right and I suddenly decrease the symptoms, then I'm looking at the AA joint as very likely to be the pain producer. Do you see how that works? Where we're just changing this one little positional thing, but we're increasing stress in one particular area, decreasing it in the other. So differential diagnosis, right? I mean, these are the puzzle pieces that we want to be able to find in order to say, okay, I'm looking at potentially this OA as being a pain producer, right? So I want to diminish the amount of stress I put on the OA. Why does it have this extra stress, right? So if I have a significant loss of movement, probably going to be a CV issue. Is it the opposite side OA, the right OA? Is it the left AA, the right AA? We have some options here, but biomechanically, we can look into those to determine which one is not moving well enough and thus increasing the amount of stress that OA joint would be put under. So we can
Eric,
get
I have
very...
a question. I'm sorry to interrupt you. I'm having a hard time picturing this because I thought the OA joint contributes very minimally to rotation. So why would I be choosing this to assess OA rotational stress when it doesn't contribute much to rotation in the first place?
Oh, it contributes plenty to rotation.
The OA?
does. Yeah, the OA and the AA both contribute plenty.
Don't think of it as being a rotation moment that occurs. It's a coupled motion of flexion, extension, side gliding. The OA joint itself isn't this idea that's rotating full, but as you do that, you're gonna have one side anteriorly, gliding, going up, the side going posterior. So it's the component motions, much like we assessed it, versus pure rotation.
And think of it this way. So if I have an OA joint, whether it's unilateral, bilateral, that cannot produce these unilateral movements, right? So if I go into left rotation, the left occiput, left occipital condyles are going to glide backward. The right occipital condyles are going to go forward. So we're going to get this sort of moment. If I have one right, say on this left side that doesn't move much, what's going to happen is all of a sudden that posterior glide is going to have to increase with left rotation. So it's going to hypermobilize that left OA potentially, right? It could go down to C23, it could go down into the AA joint. It's just a matter of how their body is adapting to that loss of mobility at that particular joint. If I have an OA joint, say on the ipsilateral side that doesn't go posterior very well, all of a sudden now when I turn the head, C1 is going to go with it. one way or the other, because now this thing's not going to do anything. We're not going to get that posterior glide. It's not going to be symmetrical. And now C1 has to pivot and do more work as a result of that sort of thing, because it's just turning with the occiput. So whether we want to look at it from a perspective of the OA contributes substantially from a percentage perspective to rotation, it doesn't matter. As soon as we start locking up things at the top, we start shifting that stress down below it, right? And the first thing in line is going to be the AA. The next thing in the line is going to be C2-3. So those stresses are going to be transmitted down the chain. So you can't turn the head without movement of the OA happening, right? That it has to. Otherwise, you're going to have to do all that extra work at the AA, C2-3, and then, you know, kind of dissipating as it moves further down into the mid-cervical spine. But yes, I would say absolutely. If you're lacking more than 30% of the expected range of motion in rotation, unilaterally especially, you're looking at a CV limitation. Something in this craniovertebral region is not moving well, and that could be at the AA, which is the more mobile segment, but it could also very much be at the OA, because biomechanically you can't move C1 without the occiput being able to move above it. Okay, so mechanically speaking, you just have to have that ability to do that. Does that make sense?
Yes, that does. So like, sorry, because I was thinking more like OA, like flexion extension, but there's a coupled moment that you rotate to the left, and that left occipital condyle moves posteriorly, and my right occipital condyle moves anteriorly. So, okay, that makes sense.
Yep.
I do have a question for you about assessing the joint mobility of the AA. I was looking through my notes this morning, and maybe I just didn't catch it beforehand, but the sense of when we're assessing AA, anterior and posterior glides, you are using rotection and latection in order to do that.
Yeah, you can. I mean, I wouldn't look at it as anterior posterior. That's a bit simplistic, because you have to consider the slope of C2, so of the superior surface of C2. So realistically, it's going to be anterior and inferior, and then it's also going to be posterior and inferior are going to be the two glides. So yeah, when you're looking at it and saying, okay, I want to assess, if I'm turning to the left, I want to assess the right AA's ability to go anterior and inferior, you would use a latection moment. Yes, you would side bend to that side down through C2-3, at least to the point where you're locking up 2-3, and then you're going to rotate the opposite direction. That should be biased to that right side AA segment. If you do a rotection, meaning you rotate first and then side bend, it would look more at the posterior slope of the AA on the ipsilateral side.
And then you're putting your pressure through C2 instead of C1.
Right? With the rotection version?
Yes, yes.
That's the easier way to do it, yeah.
Okay. Okay.
Good, got it.
Thank you.
Yeah, I mean, the biomechanics are the biomechanics. I mean, we should be getting pretty comfortable with what the mechanics are there. And there's ways to, adapt these things where you can, fix C2 with kind of a pinch grip, and you can kind of spin C1 over the top of it and whatnot. And that works fine. Or you can, move C2 underneath C1 by, and those sort of things that you can, as long as you know the mechanics, you can kind of adapt how you're going to do these things based on what the patient can tolerate. Some patients they may get really dizzy, they may get nauseous if you actually take them into rotational positions. So being able to just kind of move one segment relative to the other segment, so fix one, move the other, may be a better option for some patients that are dealing with trigeminal symptoms, because dizziness and nausea are two of the, I would say, more common issues that will kind of pop up with those sort of things. So as long as you know the mechanics, you can kind of MacGyver your way through to find a way to assess these things. Just kind of the fun way, because sometimes when you do that stuff, you find better ways to do it than the ways we were using previously.
Yeah, it's super helpful in just learning joint feels as you start to kind of play around with it, and now you're actively thinking about it and feeling it. It's an excellent way to kind of just develop your kinesthetic senses of playing with the joint in different ways versus just rotely doing what you were taught, because then you tend to just do a mechanic as you were taught, but not think through the feel of it. So the more ways you can feel it and do it and try it and fail and succeed, the more you're gonna learn.
Yep. Oh yeah, I've got. Sorry, I'm kind of looking through some of my course materials for where my trigeminal stuff is as we're going through this stuff, but little pieces here and there. That's not as helpful as I was hoping it would be. What else do we got? We have any other questions about this stuff here? Any other presentations you guys are seeing where we might be able to help make those connections for you? None, huh? Find that hard to believe.
I've got a runner, Eric. It doesn't pertain to upper cervical, but maybe get your ideas on, got a female runner, 28 years old, main complaint of right gastroc pain. Onset of pain about a half mile into her run. She's running on a level grade anywhere from 6 to 8 miles an hour average pace, I would say. Her goal is to be able to run about 3 miles pain-free, so nothing too terrible. Well, I'm watching her move, watching her walk. She has 0 trunk rotation. So I'm like, okay, I'm going to look at her T-spine and I'm going to look at her ankle and just kind of see what I find. So her TC joint was jammed up. So I manipulated that, then did some soft tissue on the calf. And then don't think I got the T-spine until visit 2, but went up and found what I believe to be kind of a restriction on her right side at T10 and 11. So
into right rotation.
Yep. It was actually more, I would say right latection. So right side bend, left rotation,
Left
right?
rotation. Okay.
So she's limited in that. So I was having a hard time connecting mechanically, but I start to think about your language around the TL junction and iliopsoas, and I'm like, you're not storing energy and releasing appropriately. So I kind of told her that, manipulated T-spine, gave her some retraining for rotation, and then I had her run again. And all of a sudden the rotation's there. She feels good. So I said, great. Day 2, go ahead and try your 3-mile run sometime today or tomorrow and see how it goes.
Mm-hmm.
She came back next week, reported to me onset of pain now at about 2 miles, was able to make it through, but had more pain after, more so than during. And then, so again, just seeing a lot of calf tightness. I'm seeing some things in unilateral right-sided, just some control issues there. So I even looked at lumbar spine. I really didn't find anything, but I don't know if it's a proprioceptive issue or a control issue. But my thought is she's just working hard on that right side to move in the sagittal plane because of this lack of rotation, because of a lack of ankle dorsiflexion mobility. So far, the ankle seems to be holding with just some simple drills I gave her. But what are your thoughts? Am I missing anything? Do I just need to give it more time? I've seen her 3 visits.
Yeah, so what I would say is it should be pretty easy to connect a right latection issue with a right ankle issue and why they might be, essentially overusing that right gastroc or the right calf musculature in order to add energy back into the system. Because if you think about it, when you're in right latection, you're going to be side bent right, rotated left. So your right arm's going to be forward, left arm's going to be back. Your right leg then is going to be back behind you, moving toward dorsiflexion, right? At least it should be if you're running like a normal human being, right? So we have that opposite movement, the upper body with the lower body. So left leg will be forward and moving toward foot contact. Right leg will be moving behind them, moving toward dorsiflexion and push off. So if you're not able to get into adequate right latection, essentially you're not winding the spring enough, right? Because the idea here is we've got the upper body here, we've got the lower body here, and we do these sort of things to wind up the trunk, right? So we wind up the lumbar, the TL junction, the lumbar spine, the pelvis, and then down into the hip. And what this does is it creates this spring mechanism. So as soon as the foot leaves the ground, right? So as soon as we get into that push-off position, that spring will release and it adds energy into the system passively, right? Because it's a potential energy mechanism. If the ankle's not working real well, that's going to be a problem. You're going to have to put more effort through the calf because you're not going to get adequate stretch of the gastroc and the Achilles, right? So you have to push harder through the calf to make that work. But the same thing goes, I mean, Dave talks about it all the time, this failed load transfer, right? This failed energy transfer. So TL junction's a good start, but we have to consider what else could be problematic on that side, in particular, that could cause issues with that energy distribution. The first thing that comes to mind for me would be the pelvis on that right side, right? So if we have a latexion issue on that side, odds are we're also going to have some sort of innominate rotation that started to occur. Whether that's an adaptation specifically to the TL junction issue, or it's an adaptation specifically to the leg length issue that's going to be developed as a result of the talocrural restriction, it's probably there. And then that's going to affect kind of the motor output that you're going to be able to get from the psoas major. Basically, the psoas in that position, where the right psoas, I should say, to be specific, as the leg is starting to trail behind you, this is how we get these latexion moments, right? As we're looking at that muscle coming off the front of the spine, so off the front of the transverse processes, it's going to produce extension of the lumbar spine, ipsilateral side bending, but contralateral rotation, right? So coming off the front of the if these are the transverse processes, it's going to pull them forward, right? So pull them forward, that's extension. Pull this down, that's ipsilateral side bending, and pull this side forward, that's our contralateral rotation. So if we're not able to generate, or we're not able to get adequate stretch of that psoas major due to, number one, probably the TL junction restriction, but also potentially some sort of innominate rotation or some sort of issue within the pelvic mechanism, that would certainly affect the energy output. And again, because the psoas is really designed to control all of these components together, histological studies have shown that the psoas has more fine motor fibers than any musculature found outside of the face or the hands. So we know that tends to signal control, right? And when we're talking about it going from T12 all the way down into the pelvis, crossing over the pelvis, and then jumping over the hip, we've got a lot of components that it has to be able to control, which makes good sense that it would have that fine motor makeup. So that'd be my first thought, is you're likely dealing with some sort of pelvis issue. Like I said, whether it's a result of the TL junction issue independently, or it's a combination of the TL junction issue and the ankle issue you found, or if it's just coming from the ankle issue, you've got to be able to do some clinical reasoning here and make a good clinical judgment on which one you think is the primary cause. If the ankle is holding up, like you're saying it is, and she's still getting the issue, the ankle is unlikely to be the main driver, right? Otherwise, fixing the ankle and good carry over the ankle issue would probably have alleviated most of the problems. Now, it's possible that she still has some sort of tissue damage within the calf area, and that may just require some time to heal. That's definitely a possibility. So it could have been you let her jump back into that running, that distance a bit sooner than the tissue in the calf is physically capable of managing. And that could just be a couple of weeks worth of, maintain this mobility stuff, work on some eccentric loading through that calf if there is some tissue damage, to minimize scar tissue formation, and help improve elasticity there. But my suspicion is, because you have the ankle issue, something below, and you have the TL junction issue, something above, there's probably a pelvis problem that's lurking in there somewhere as well. That'd be my first thought. What do you think, Dave? You got anything else you want to? I know you see a lot of runners. You're muted though.
There it is. I'd play the hip and pelvis off the foot and see the mechanics. And again, even don't forget about just the basics. Okay, where's her landing? Where's her strike pattern? You 4-foot landing, it's going to increase the load. Is she rear foot? Is she rear foot or mid foot striking? What is also occurring there locally? At the site, what puts extra stress on. I mean, we looked at a runner like 2 weeks ago, and one foot was rear foot, the other foot was 4-foot. Don't overlook some of the obvious things too when you get in this sort of thing. Yeah, it was weird. And so look for those tendencies that would also be there, but you're also probably looking at the system, because even though you have that, why are they doing that? Is there something higher up that's making them? What's the cause and effect of this? Is there a pain they're trying to get away from, and what they're doing? So definitely look at those mechanics. If she got better with TL junction, you have better energy moving through the system. That takes some time. She can run longer, but what else would be overloading the calf system? Right. Look, pelvis and pelvic mechanics would be kind of the primary thing. Hip and pelvic drive, proper drive, to do that, because running is more hip driven than calf driven. So is she trying to use a calf driven strategy? And likely that would be just decreased drive pelvis.
Yeah. It's always interesting stuff to think about, the possibilities of where things can come from. I mean, obviously we're not looking at the person. You're the one looking at the person. You'll see what they're doing. But I've found that runners, for whatever reason, they are notoriously stiff through the thorax. And it's really irritating to me. Like, why? You'd think most runners would be mobile, would be flexible, but they are just not. They are stiff through the rib cage. At least that's the experience I've had. And I treat a lot of endurance athletes, a lot of marathoners and triathletes and stuff like that, and they're just always stiff through the rib cage. I don't get it. I've thought about it for years. I still don't have a great explanation as to why that's the case. My suspicion is it's some sort of fatigue mechanism. As you get into some of those longer slog runs and whatnot, they stiffen up and they start to the spring mechanism starts to fail on them. They start to develop some of these compensations, like, my hips getting tired, my ankles, my calves getting tired, I'm running uphill or I'm running downhill, and things start to fall apart. But when you look at that and you start thinking about, well, what else is going on with this person during a run that's affecting the rib cage? Well, they have increased oxygen demand, right? Sustained increased oxygen demand, which means respiratory mechanics start to come into play, right? And I think respiratory mechanics in general are probably one of the biggest reasons for the difficulty that most therapists will have in maintaining mobility through the rib cage post manipulation, right? I mean, because I say I probably manipulate 90% of the rib cage lesions that I see when they come into the office. It's just they tend to be subluxed in those areas, more so than the neck, or particularly the lumbar spine. Lumbar spine, I probably only do maybe 10-15% manipulations on the lumbar segments. But it's way higher in the thorax. But we can get great results. We can take them through the ranges of motion afterwards, and everybody's like, "Oh my God, look how well I'm moving. Everything feels so smooth. This is great." And they come back 2 days later and everything's jammed up again. When you're sitting there going through your head like, "God damn it, what did I do here? What did I miss?" I tend to think it's nothing that we missed in particular, because I think that's a bit of the imposter syndrome that starts to come out of us when we start to have difficulties with carryovers. We start thinking, well, there's got to be something else. I'm looking elsewhere in the thorax. I'm looking in the lumbar spine. I'm starting to move myself around, jump from place to place. When in fact, I think, and I really believe, that the habitual mechanics that occur with respiration of the ribs, right? Movement of the ribs, the spinal segments, everything that occurs with with breathing, mechanics of breathing, it's such a habitual movement and it occurs so often that it's very hard for the body to break those habits of the compensation that it's come up with, right? So I liken it, you take somewhere around upwards of 1,000 breaths an hour, which sounds like a lot, but it is. you know, so that's one of those things that we have to take into consideration as we're doing our rehab programs with these patients to try and maintain this mobility, because we're looking at it from a perspective of, well, we can't keep this stuff moving. But if think of a golfer, you know, a golfer goes out onto the driving range and takes 1,000 repetitions with poor form. How difficult is it going to be for that golfer to change their swing to perform it with good form? It's going to be tough, right? So you start thinking about somebody, just anybody, anybody that walks into your clinic, but especially somebody that has increased oxygen demand, increased respiratory rates, like runners, for instance, sustained over long periods of time. How many repetitions does this person take with poor mechanical patterns, right? Poor neuromuscular patterning. And every single repetition that person takes reinforces these poor mechanics. It's exceptionally difficult to break those habits, right? So for me, the best thing that we can do for those types of patients in order to maintain those thoracic mechanics is just to maintain the mobility of the thorax. The body is an efficiency engine. It wants to move as efficiently with as little energy expended as possible. So if we can show the body that it's physically capable of getting through these movements with less energy burned, which should happen with normal mobility, right? Normal mechanics. The body should pick up on those habits. It should pick up on those movement patterns, and the central nervous system then should step in and help us to decompensate those problems. We have to force that stuff right into its face. I think I talked about it during the Module 3 class. So this may be a bit of a, review for you guys as in regards to that sort of stuff. But I tell patients, I want you doing anywhere from 10 to 20 repetitions of some sort of rotational mobility exercise. I use a wall windmill where I have somebody up against the wall and I have them spinning on a wall, because I can put them in a stride stance, which is more similar to what they would be in when they're running anyway. And I tell them, I want you to do anywhere from 10 to 20 repetitions of this every hour that you're awake during the day. Wanting to get a lot of movement out of it. We used to say, or at least I used to say in my clinic, we want you to get 100, maybe 150 repetitions of this done every day. Patients would wake up first thing in the morning and they'd do 100 repetitions before they got into the shower, and they didn't do none of it for the rest of the day. And we started realizing, well, we need to have this be more, like I said, habitual. So having them do it just periodically over the course of the day, every hour tends to work very well. If they miss an hour, it's not the end of the world. But it tends to be much better for the maintenance of that mobility through the rib cage than it is just, telling them to do this 2 or 3 times a day. That just doesn't seem to be enough to make it a habitual movement for the body to recognize those movement patterns and to help step in and have that central nervous system help to fix this stuff for us. Because realistically, we want the body working with us. We don't want to be banging our head against the wall trying to fix it ourselves, which seems to be the case sometimes with thoracic mobility. But anyway, I'm on a soapbox about it. What else do you think there, Dave?
Geez, hard to kind of follow up with the soapbox, isn't it?
Always is, right?
Yeah. The thoracic spine, you do see different body types in it. That's always the idea. Is it the compressive force that's repeated that starts to compress the thoracic spine? It becomes just from the vertical reaction force. But you're right. It get that, okay, what's going on in the respiratory component that makes this more efficient? Where is it more efficient from a respiratory standpoint to give up some of this mobility just in the draw, the tissue and breathing? And it's probably a very strong influence what we see. It's also a body type you see. I mean, the person I see who's tighter is going to be that smaller built runner, somebody who's probably more an elite runner, or somebody who runs more tends to have the stiffer thorax. So to some degree, it is about that individual and their volume and their training effect versus the casual.
It's
He
all,
just realizes he's on camera.
all great stuff. Thank you guys. Yeah, I'm laughing a little bit because she is very short, but she's kind of stout. Forgive me for saying it, but she's kind of built like a curmudgeon. Kind of looks like very just short and squatty looking, you know, and no rotation. But that's all great stuff. Thank you guys.
Got a few minutes. Let's wrap back around with trigeminal facilitation real quick. I sent an article a couple weeks ago. You know, worth kind of taking a peek at. Definitely take a peek at the article if you haven't already, because really where this individual, what you end up doing is you end up manipulating upper vertebral joints. Somebody who's had MVA history of ear injury 19 years prior. So the case here was a 65-year-old woman presented outpatient physical therapy for treatment of neck pain, dizziness, and headaches, which is pretty common in what we see. You know, this was 19 years later, skip down, blah, 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 no pathology found in MRI imaging. You know, approximately 10 months before, you know, the current therapist evaluation, she began feeling tingling in the left side of her face, cheek, and jawline. Tingling prompted return for medical care, where she was cleared by cardiac pathology and remained without a diagnosis. You know, and she talks here about physical therapy, particularly dizziness lasting 10 seconds with lying down from a seated position. So, you know, generally there you can think orthostatic as well, but is it also, in her case, maybe change in head position? But, you know, that doesn't really clear up in those two items. Intermittent sharp pain, you know, again, top and left of her cervical spine, headaches that began in the posterior aspect of her head and travel to her left eye, stiffness and loss of neck motion, itchy pain in her left eye, left-sided facial tingling. And she also, unfortunately, she felt like she was looking through a dirty window. So kind of a lot of things that Eric had mentioned.
Yep, sounds very familiar.
These mixed bag of symptoms. She felt better in a dark, quiet room. I mean, lack of stimulus and neural input is probably the reason there. You know, pain 8 out of 10 with activity, 2 out of 10 at rest. You know, occasionally take ibuprofen will only minimally help to reduce the pain. You know, reading for longer than 20 minutes, you know, increased her headaches, pain. Down here a little bit too far. I can go much in history, but what I wanted to cover here in these few minutes was just a sense of the history of this individual. You know, this is an individual where in this case study, I believe what they found was, you know, C2, C3 hypomobility driving it. And I think in the first treatment session, what they did was manipulating C2, C3 cleaned up a good bit of this. You know, they also noted in that area, what we talked about previously as well, is that, you know, atrophy that occurs in these areas where we get this irritable input or nociceptive input or even this lack of motion. And with that, you're always going to find your poor recruitment of your deep neck flexors, noted with your deep neck flexor test, and a compensatory firing pattern or sternocleidomastoid, which is really quite the typical pattern that you see. That's kind of where with this course you can't really get into that depth of, if you're just looking at this from a muscular and exercise standpoint, then yeah, you can do deep neck flexor exercises. You're going to work on the rebalancing of that. But within there, you know, you'll tend to miss the primary driver of the C2 or upper cranial vertebral dysfunction being the thing that probably needs to get addressed first or progressing into any type of deep neck flexor and door training or trying to rechange that balance between sternocleidomastoid and longus colli and longus capitis in these cases. So, you know, just a point of emphasis, you don't abandon everything else like I don't need to do those other things. You will, and you'll spend a lot more time doing those than you will manipulating the neck. But to get an immediate outcome with this one, that needs to be addressed first. And real quick, this chart was give us what they found in this individual. There's a hypomobile extension, have them on the left 2, 3. And it looks like in the second section, hypomobile anterior inferior pathum of the right C1, C2 with normalized end field into extension of L2, L3. So first session manipulated 2, 3. Second session, you know, manipulated 1, 2. with, you can read on it here with resolution of symptoms. I think she got resolution of the visual symptoms after the first treatment. And downright being saw significant improvement with this. So, okay, a little short on time. Great case to review. Wanted to go over kind of the highlights because you see how fast this person's improved. And here, by second visit, 4 days later, even before they did 1-2, 80% improvement in facial tingling, numbness, and visual impairment was noted. So, real good case to go through for prepping for trigeminal facilitation and what they saw and how they described it. I thought this was kind of like, almost felt like they made the case up. It was so clean. But
this is like straight out of my notes on this stuff.
yeah, this is Steve Karras, who he was also kind of under Earl Petman, did a lot of work in there. So as you read it, it's like, oh, okay, I have to know who wrote this. I looked at the name, I'm like, oh, okay, I get it.
Yeah.
So he's somebody.
I just found all my notes on trigeminal stuff, so I can get that over to you, Dave, and we can
great.
put that up. Because it's a bit of a deeper dive into some of the potential symptoms.
But this blends over into everything else we're seeing, whether these are vestibular patients that fall into your lap, these are post-concussive patients that fall in here. They could be the post-MVA patients with whiplash. It could just be that older person with idiopathic neck pain that's getting funky symptoms. Or they could be Patrick, who just has a loose, floppy head that's oversized, and now it's all stressed when some guy's been yanking. You're welcome, Patrick.
We'll take it as a compliment.
Please do. But no,
it's
because
nice... his partner was so strong.
I was worried about that. That was my primary concern in that class. Is how buff.
Crazy.
How buff. All right, guys. You haven't reviewed it. Read the article. We'll get more information out. I'll post some stuff for the next couple of Zooms coming up based on what we're doing in the class. I still need to get a hold of you, Eric. Sorry, I've just been getting walloped recently.
That's all right. I've had a bunch of stuff going on anyway, so we'll figure something out.
Can you, if you find the videos from, I think it was module 5 they're looking for, I could not find them. I remember I thought you sent them to me, but I did not locate them.
I thought I did, but I can send them over again, I guess.
Send them again, that'd be great. Yeah, I somehow cannot find them in my logs. Thanks.
Yeah, no problem. Do you want them just on the Dropbox, or do you want me just to email them to you?
Either whatever you.
Okay.
Doesn't matter. Least amount of steps.
Gotcha.
All right.
Cool.
Take care.
Yep. Bye.